to Roots of Resilience, the series where you strengthen foundations so institutions and their people can thrive in adversity. I'm Dr. Teranda Knight. I'm a doctor of behavioral health. I'm a behavioral health consultant and coach, and I am the CEO and founder of Virtually Renowned Consulting Access LLC. With a polymath lens across policy, clinical practice, student success, as well as leadership ethics, today's conversation on silos versus systems in campus behavioral health and why integration matters. So, what the evidence actually says and how you can begin without waiting for perfect reorganization. So, first, I want to talk about what the evidence says because evidence is exceptionally important to us in the field. It's what helps keep us rooted, right? And of course, having those roots in resilience or of resilience, you actually have to have a great foundation because it's all about the foundation. The foundation is what determines our success. Now, the core idea of integrated campus behavioral health is simple. Align counseling, primary care, psychiatry, case management, and academic supports so students move through care without friction. That alignment, practice integration can exist even without merging departments. So let's take a look at a national survey of college health centers found significant higher practice integration when behavioral health clinicians are embedded in primary care, independent of administrative mergers, and in short, collaboration at the point of care moves the needle. Let's review level evidence that shows mindfulness, CBT, which is cognitive behavioral techniques or therapy, and technology enabled supports reduce student anxiety, depression relative to passive controls. So, with CBT, the effects are more likely to sustain over time. And so, this is what the research tells us. So, for students with severe symptoms, collegiate integrated primary and behavioral health, which was what we call IPBH, programs demonstrate positive growth trajectories across multiple service combinations where counseling, primary care, and psychiatry is offered and provided all together. When we look at the DBT informed intensive services in university settings, they show meaningful distress reduction with telehealth sometimes outperforming in-person care on overall distress, key for commuter and working students. And why is that? So telehealth allows us to receive our level of service care or communication anywhere. I mean, we can be across the world and still receive the level of care we need with telehealth. And that's the uniqueness of it. We want to maintain some sense of face to face connection, but most of the time it's not even relevant to care. Care requires you to listen and to actually be able to provide what the actual individual needs to help them navigate what they are going through. And it doesn't take a face to face visit for that. Why? Because you can't have any physical interaction. That goes against ethics. So when we look at a complementary insight from broader collaborative care research, the active ingredients tied to stronger depression outcomes in primary care include manual-based psychotherapy and where appropriate, family involvement. Campuses can adopt family engagement with careful consent and student autonomy. Let's take a look at common barriers you can name. You don't have to name your program integrated to solve integrated problems. Start by naming the barriers. Referral friction and lost warm handoffs. A student gets screened, but there's no shared queue or same day introduction. How does that make sense? Next, access gaps. Even telehealth blocks matter. Students balancing work and family are underserved. Without them, we see it with the actual evidence that telehealth can equivalently and effectively, and sometimes even provide the better sense of care that individuals need for the overall distress that they have. Next, measurement-based care, using standard procedures or measures such as the PHQ-9, the GAD-7, and systemic identification is tied to better depressive outcomes in collaborative models, especially with specialist supervision and case review. Now, the reason you hear me talk a lot more about depression and anxiety is because those are the top two things that majority of most students experience. And as a result of that, it changes the way they eat and they take care of themselves, which increases their risk of hypertension, diabetes, whether currently at their current age or state or further down the road. And we want to be preventive. So if they haven't gotten to the point where they're experiencing those health conditions, we want to be able to provide them with the support they need now to prevent it from along the way. Give them the tools that they need. Next, outcome transparency. Multiple campus data demonstrate college counseling centers reduce distress and suicidal ideations or thoughts of unliving yourself during treatment among students with past self-injury or thoughts of unliving themselves, strengthening the case for resource centers and case management. Let's take a look at some practical starts. These are just some things you can think about. No proprietary playbooks, but just these 3 non-proprietary actions you can begin this term. First, have weekly case huddles. These case huddles have health, counseling, and case management meet, review, step care decisions. Collaborative care literature shows multiple professional communication and supervision are core components of effectiveness. Second, hybrid access guide or grid. Add evening telehealth and skills-based CBT and DBT groups. Add a little ACT, which is acceptance commitment techniques in there with that as well. The review of evidence support. The CBT mindfulness for student anxiety and depression alone can help them with making sure the schedule is an equity tool and it provides them with what they need overall. And then third, outcome quartet. Track the PHQ-9 and the GAD-7. Use it as a quality-based tool. Utilization, crisis events, and continuation to next term. Compare against multiple campus trends for context, because those are the things that's going to help lead to the success and outcomes of the great things you're doing on your campus. When we look at these factors, we can think from the concept of we're addressing things from a communication factor, we're addressing it from a quality factor, and we're also addressing it from the sense of making sure that everything flows across departments. Knowing that whether you are the healthcare provider or the case manager, or maybe you are just the person that is the support staff. Either way, the only way to break the silos versus the system is to take part in identifying the importance of knowing that counseling, primary care, psychiatry, case management, and academic supports are all needed for student support. But most of all, the barriers, identifying them, identifying that you don't really communicate like you should. You don't give those nice warm handoffs that allow us to get a brief, clear picture of the student. Now, the next segments that I have, we'll talk a little bit more about the use of FERPA and HIPAA in these type environments, because there is some important things to keep in mind. When we are dealing with factors that just include the healthcare professionals or human service professionals, then we're falling up under HIPAA. And HIPAA is something that protects any health information from being shared inappropriately. Okay? And when we think about FERPA, it's for all the higher education professionals that is also trying to help with the student success, but making sure that we are protecting their educational information. Now, many of you say, okay, well, how can we actually help the student if we cannot talk to them about their healthcare? We cannot talk to the higher education professional about their healthcare and the higher education about their healthcare and vice versa. Well, guess what? You have offices for disability, and those offices for disability and accommodations on campuses help students with making sure that the factors that they are having identified can be accommodated while they are on their educational exploration without sharing too much information. But also help us with identifying those triggers and things we need to. So remember, practical starts with 3 non-proprietary actions. And remember, go ahead and start them today. Have those weekly case huddles. Think about it from a 30-minute standpoint. That's reasonable. They're quick. They give a very detailed overview of the actual student that doesn't violate any of the FERPA or HIPAA compliances for campuses. And then second, remember hybrid access grids. Having even in telehealth, skill-based CBT and DBT groups, maybe some ACT added to that with some groups. Maybe some groups that are geared towards the actual factors you see that your students are struggling with the most on campus. Make it a little bit more non-therapeutic in the sense that they feel like they're being diagnosed or categorized, but more so like they're making a connection with those that are around them to succeed. And then the third one, the outcome quartet. Remember, track those PHQ-9s and those GAD-7s, and we can talk about even more quality-based tools you could be utilizing to help capture the information needed, because the more you capture, the more you're able to apply for those fundings and support needed to help your students get to where they need to be. So, as we close, integration in is a behavioral health change among teens, not a branding exercise. Because most of the time, students feel as though they come to get help, and there's more focus on the diagnosis than it really is their treatment plan or care plan, right? And we want them to remove a little bit of that technical based factors that makes them feel as though they're being diagnosed or that they're being treated as just another statistic. Well, these are just ways that you can utilize your therapeutic factors, but also look at it from how you can navigate into ways that makes the student feel more comfortable with what you're providing them. And no, name a pilot cohort and commit to 12 weeks. That is what my services are all about, helping you do the necessary assessments of where you are to identify where you can be and what's needed to get there. Sometimes that outside lens help you gain more insight than you ever can for those that's working in it every day. And it also removes the bias, because remember, sometimes we're more willing to push things to the side when we feel as though we maybe have failed or we don't want to identify it because we feel that it may have been inadequate. Well, guess what? That's okay. Identifying the inadequacies is what builds that level of growth that we need to see to also help the students be as successful as they can. Because student loans are growing every day. Education is not getting cheaper, and we want to make our students feel like it's worth it, not just for the college or university, but for them as well. And make sure you are embedding those PHQ-9s and GAD, GAD-7s into your actual intake. And every 4 to 6 weeks, make sure you're doing that review of the information that you're capturing from that. And that's where my services can step in and help as well. Let you focus more on the patient aspect of care for the students and support, while I can focus on the quality aspects of gathering the information from what you're gathering during those sessions. Launch evening telehealth before midterms is so helpful. Helps you identify and capture the things that's leading to that depression and anxiety in students, and identifying where maybe some change can be made in policies and processes. But make sure we're monitoring and having those utilizations and symptom change. It's a fascinating aspect of our world today in higher education and behavioral health, where the two actually meet themselves to help human beings improve their lives. Because whether they get their degree or not, the tools you provide them while they're on the campus could be the very tools that could save their lives, whether they get their degree or not. So if today sparked ideas, go ahead and visit me at www.virtuallyrenownedconsultingaccessllc.org. Get a little bit more information from the articles and tools that I have, but also go ahead and get scheduled today. And know that if you stay up to date, if you subscribe, you'll automatically receive articles and tools in email to you monthly. So go ahead and follow me on TikTok and at Never Fed the Beast. Know that's the brand because we want roots of resilience. And across social for weekly insights, go ahead and follow me on Facebook and Instagram as well as LinkedIn. And remember, never feed the beast, never fed the beast, and we're going to have roots of resilience in 2026 because we would not have it any other way. And I am rooting for you and your success. And until next time, be great.